When patients are intubated in the ICU, these are the type of patients you're going to have on continuous sedation. Now, the sedation we typically use is something like propofol. Occasionally, you'll see dexmedetomidine or Precedex being used as well. And I'm going to take you through kind of the benefits and the risks of using this sedation. So in terms of what we're targeting for our sedation, there's something called the Richmond Agitation scale, which nurses can use to adjust their sedation, either go up on the dose or go down on the dose. Normally, we target a score of -2, which is what we consider light sedation, where a patient will wake up to, if you say their voice, and they may be awake for about 10 seconds and then fall back asleep. And then 0 is someone who's alert and calm. Now, the opposite ends of those spectrum are +4 would be someone who's combative and you're worried that they're going to rip out their lines or their tube. And then the opposite end of that spectrum is -5, which is basically an unresponsive patient to painful stimuli. Now, the biggest reason we use sedation is to, one, reduce the risk of patients pulling out important lines like their breathing tube, or if they have like central access or even like ECMO cannulation, that anything that's really life supporting or life saving. Now, the flip side of that is the longer that we keep patients sedated, the more likely they are to be delirious or just kind of have no idea what's going on around them. And when it comes time to wake them up and extubate them, they may be very confused and it may take a long time for them to recover their neurological status. So what we typically do to combat this is that we'll wake a patient up every day and basically assess their mental status. So nurses will lighten the sedation, wake them up, basically ask them to move all their extremities just to make sure they're neurologically intact. And if they start to get restless and really agitated, then the nurse will put them back to sleep by going up on the sedation. What research has shown us is that by doing these sedation awakening trials, we're basically able to reduce the amount of delirium patients may have and also get them closer to getting extubated sooner than if they were just in a deep coma for a prolonged period of time and you were just looking at the ventilator to see if they were ready to be extubated. So what we do daily in combination with spontaneous awakening trials is what we call spontaneous breathing trials. And so that's when we put the patient on minimal vent settings. You try and decrease the amount of FiO2 that the patient's taking in, put them on a spontaneous or pressure support mode, try and minimize how much support they're getting from the ventilator, and kind of see what type of tidal volumes they're taking in, how fast they're breathing, and that combination kind of gives us a sense as to, is this patient ready to get extubated or not?